Good morning, everyone. Thank you for joining us this morning. Hello and welcome to the Texas Covered Conference brought to you by the Texas Association of Health Plans. My name's Jamie Dudensing. I am the CEO of the Texas Association of Health Plans, and it's my honor to welcome you here. I hope you've already had a wonderful time this morning. I can't express how great it is to see everyone. Some people for the first time in almost 2 years. As many of you know, we haven't been unable to host the Texas Covered Conference live and in person for almost 2 years, and a lot has happened since then. As a healthcare community, we all came together to meet one of the biggest public health challenges in our lifetimes. Health plans have played a significant part of that response. Our health plans in Texas, Medicare Advantage, our commercial plans with our employers, and our Medicaid managed care plans all played a significant part, which included things like eliminating out-of-pocket costs for COVID testing and treatment, expanding the use of telemedicine, helping people have easier access to telemedicine in their homes, or helping doctors' offices access telemedicine for the first time. And including doing things like extending grace periods for premiums, and in the end, just being there to connect families to whatever services they needed to get healthy and stay healthy and keep their families healthy at home with them. We've all been tested during the COVID-19 crisis, and I'm proud to say our industry's resolve has never been stronger to take care of Texans. As you know, medical care is only one part of what determines health. And now our health plans are stepping up to take on factors such as education, access to healthy foods, safe housing, employment, all items that play significant parts of reducing healthcare disparities and overcoming the obstacles of access to social barriers that many individuals face. And as a result, health coverage has become more valuable than ever, and Texas families are empowered to live richer and fuller lives. And we're seeing those results. We've seen Texans this past summer during the special enrollment period, we've now seen a 40% increase in Texans purchasing health insurance on the individual market, really showing just how important it is to have access to affordable coverage that gives you access to affordable health care. But at this conference, we're not just talking about health coverage. We are bringing together leaders from the entire healthcare community to not only discuss lessons that we've learned from COVID-19, but also to see if we can replicate that same level of innovation as we look for solutions for the other monumental challenges we all work together to overcome to provide the best health care possible for all Texans. And as we get started, I do have a few housekeeping items for everyone. I'm going to go through these first. Let's see what we got. Is it working? So as you guys know, we do have a hashtag, THP 2021. Please, tweet, be involved on this. We also have our mobile app. I think over 500 of you have already downloaded it, but please get on the mobile app. You can share connections, meet other people. It's such a great opportunity now that we're all finally here together and getting to see each other. And if you need anything, I would say I don't know if I can't see back there if I've got my team all in here. Can you guys walk up to the front real quick? Whoever is in here, so that you guys know we've got Jason Baxter is our Director of Government Relations right over there. Patty's gonna be hiding. Patty Donor, who all of you have talked to multiple times. And I will like to say she really appreciates all the support we get from our plans and our sponsors and everyone that helps partner with us. Melissa Eason, our Regulatory Counsel. Amanda Hudgens is our Director of Health Plan Operations. It's Amanda. Blake Hudson, who just started with us today, is our new Director of Public Affairs. Where's Blake? Did we lose? Oh, there's Blake. I stole him from AARP. But we are very excited to have Blake be a part of our team. Alicia Pierce, our Director of Communications. We got Madeline Richter-Atkinson, our Communications and Policy Advisor. And last but not least, many of you also know Lori Van Hoos, our Director of Policy here at THP. So if you need anything during this conference, please find one of us. We are more than happy to help. Or if you need help setting up meetings or doing anything as a part of your experience here, just please let us know. Thank you, guys. And then, of course, And of course, none of this would be possible without our very important sponsors. And some of our main sponsors that we have today are Evernorth, who is both our keynote and diamond sponsor, Lineagen, New Century Health, Exact Sciences, HCS, and Simplify Healthcare. And look for information from our other great sponsors, many of which will be in the trade show this evening and tomorrow for lunch. Please introduce yourself. There's so many neat new companies and so many neat new ideas out there in healthcare right now, so many innovative items happening. So many, like I say, thank you so much for the many, many sponsors that we've got here today. And last but not least, we have our keynote speaker who's about to walk up here. And speaking of solutions, our keynote sponsor is to kick off this conference, who is respected not only for his solution-centered approach, but one that is based off of data. And I know we're all ready to get to our keynote speaker. And because we have such a great keynote speaker, we also have a top-notch speaker who's going to introduce Fred Bendanya from Express Scripts. Fred, if you want to go ahead and start walking up. As Vice President and General Sales Manager, Fred oversees the strategic management of all health plan, public sector, federal client activities. He came to Express Scripts in 2017 with more than 20 years of experience in sales and marketing. And we are very happy today to welcome Fred and Express Scripts for helping us out here at the conference. Thank you again, everyone, for joining us.
Good morning, everyone. I can't tell you how thrilled I am to be here, not on Zoom, not on WebEx, and live and in person here in the great state of Texas. As Jamie said, my name is Fred Bendanya, and I am privileged to serve as the Vice President and General Manager of our Health Plan Division at Express Scripts. As I hope you've heard, and you will definitely see throughout this conference, Express Scripts, along with our colleagues from Credo, our specialty pharmacy, Evacor, our medical benefit management organization, and also MD Live, our virtual care organization, we are all now part of Evernorth. You'll hear a lot more about it, hopefully, as you stop by our exhibit booth throughout the conference. Evernorth is our new health services platform, and what it does is it meaningfully combines pharmacy, medical, behavioral, and virtual with and for our health partners. We'll tell you a lot more about it, so come visit us. On behalf of my colleagues attending the conference across the 70,000 team members from Express Scripts, Cigna, and Evernorth, I'm thrilled to be with you all today. Again, be with you in person and to share the story and the many stories that we have across our industry. Based in Washington, D.C., Dr. Marty Makary is the professor at the Johns Hopkins School of Medicine and the author of the New York Times bestsellers, The Price We Pay and Unaccountable. He is a leading voice for physicians in the Wall Street Journal, the New York Times, the USA Today, HEB, and is editor-in-chief of MedPage Today. Dr. Makary has published extensively on medical innovation, quality measurement, specialty issues on vulnerable populations, and healthcare cost. He served in leadership roles at the World Health Organization and has been elected to the National Academy of Medicine. He also leads several national grants on healthcare transparency and the redesign of healthcare. Very impressive keynote speaker that I'm thrilled to hear a lot about. Please join me in welcoming Dr. Makary to the stage.
Okay, we're in person, finally in person. Thank you, Fred. It's good to be here. And I will say welcome to any cyber criminals that are hacking into the streaming platform. It's nice of you to join as well. I am so grateful that we are in person. Thank you for doing this conference in person. I took boosters every day this week in preparation. I did the tests. I did 5 tests, and one of them came back negative. So I'm ready. I'm ready to move. Is anyone else ready to move on from COVID? Oh my goodness. Man alive, I feel like I've just took a bath and I'm dirtier. Thank you for what you're doing here with the association, TAHP. Thank you, Jamie, for your leadership. Jamie is an incredible human being, isn't she? I've gotten to know her. I mean, I was setting up my laptop here, and just to tell you the kind of person she is, she said, here, you can use my password, Texas #1. She said it's her password for everything. Thank you. Patty, thank you for your hospitality here and putting this on. Everybody loves you, it's pretty clear. It's good to be with people in Texas, the friendly, warm hospitality and generosity. It's very refreshing. Lauren, who's actually from Annapolis, Lauren, who's an amazing expert in Medicaid policy, is from the area where I went, where I'm at, and back and forth. So it's great to see you, Lauren. Lauren, actually, I learned, spent some time all over the country, including in Canada, which Canada is an interesting point. We have a bunch of people who are Canadian on our research team. And I don't know why. It's this interesting serendipitous thing. But we joke around that a Canadian is essentially an unarmed American with health insurance. And Fred, thank you, and it's good to see folks here, not only from Evernorth, but Centene and 3M and Blue Cross Blue Shield of Texas that does a nice job with our work at HEB, a company I advise, and Cigna. So thank you, everybody. You are the representative of the American patient. Everybody is getting rich in healthcare right now except for one person, and that is the American worker. And you represent them. They don't have a voice at the table, and you are their representative. So thank you for your important work, and that's why I'm so excited to be here and to have so many conversations with so many of you before and after. Avik Roy is here. He's going to be on the panel next. Dr. Roy, good man. He knows his stuff, and I'm a surgeon by training, so when people ask me questions I don't know the answer to, I just make something up. He can give you the real answer. When people ask me questions and I'm getting kind of annoyed because I don't know the answers, I just recommend surgery. And then they stop. They suddenly stop asking questions when I recommend surgery. One thing I love about Avik and Fred too, Fred was born overseas. Those of us that are second and third culture kids tend to be hyper observant of things in society, including healthcare. There's a phenomena where you feel like a guest in society. My family is from Egypt, and has anyone here ever been to Egypt? Okay, good. You have a nice experience there? Okay, it can be mixed, but I'm glad it went well. It's very congested, but the people there are wonderful, and it's a wonderful country. I have an aunt who works there in ministry named Mama Maggie, and I go to visit her once a year. My partners, when I came down here, they say, where are you going to this time? And I said, I'm going to Austin. And they said, oh, cool. When I went to Egypt, they said, oh, where are you going to this time? And I said, I'm going to Egypt. And they said, is it safe to go to Egypt right now? I said, we live in Baltimore. People sometimes ask, who is this funny-looking guy talking? And I say, I was born in England, which is why I can slip into a British accent. I'm from Egypt, which is why my skin is dark. And I was raised in the United States, which is why I have type 2 diabetes. Now, one thing growing up is my mom had taught me that you can't believe anything you hear from the government. In her upbringing, everything was part of state-controlled television, and so you really couldn't believe or trust anything you heard. So anything she sees on the news, 100% of it, she says, that's not really happening. And we were even watching like the volcano in Hawaii a couple years ago, and she said, that's not happening. I think those are doctored images. I'm like, Mom, it's right there. It's on TV. And anything that's happening, hurricanes, floods, government says anything, she says, I'm not believing that. Those are, I'm sure they're doctored images. And so my mom has had this general skepticism. And I think I inherited a little bit of that in our research approach on our team. Well, a few years ago, I was invited into the White House to advise. I have advised the last 3 presidents, and this was about 5 or 6 years ago. I saw this amazing painting in the hallway on the way to the West Wing to the Oval Office, and I thought, I know that painting. I grew up near the Delaware River in Pennsylvania. I've always been a fan of American art history, and I said, that's the famous 1851 Emanuel Lutsky, The Crossing of the Delaware. And the person guiding me back said, do you have any questions about it? I said, I don't know anything about it except that it's the 1851 Crossing of the Delaware by Lutsky. And he said, well, do you have any questions I can answer for you? And I said, yeah, is that the original? And when you ask a question and then you realize, what a stupid question. And he's like, yeah, of course, that's the original. And I said, of course, yeah, I figured that. And I went home and researched it as soon as I was done with the meeting. And I was a little deflated to learn that Washington never crossed the Delaware on Christmas Eve because the generals always stay behind as a part of any military tactical force. And I also learned that women were not in the Continental Army on the oars of the front boat. There was no ice in the water. It wasn't that cold on Christmas Eve. There was no light in the background or angel descending or whatever's happening back there because they crossed at 2 a.m. The horses were not on the second boat. The Delaware River, wherever you can walk across it, I don't know why they'd be taking a boat when the horses could walk. And they didn't have the American flag on a gold post knowing what it was going to look like 112 years in the future. And Davy Crockett was not on the rudder. And I said, Mom, you're right. You cannot believe what you're hearing. And my mom was like, I told you so. This is exactly what you need to question at every point in life. Well, in healthcare, we have so many of these inspiring stories. And this, in fact, is an inspiring story. The British held the New York City area till the very end of the Revolutionary War. New Yorkers really didn't want to secede from England. They were fine. Life was good. Tax on tea. They didn't want to go to war over that. Life was good. So the British held the New York area right until the end. And Washington and his army got very lucky in a series of things, and this was sort of the final battle crossing into the New York area, which is why it was so significant. That battle was far more complicated than this painting suggests. Similarly, in healthcare, we've seen our own research get blown out of proportion where people think that the central line associated protocol to reduce CLABSIs in the ICU is a silver bullet for healthcare. And we've had to say, no. Look, we authored that work. It is just one small area of preventable harm where we could do better. Similarly, with the surgical checklist that we developed, we had to quickly rein in the enthusiasm to say, yes, we need to be doing this, but this is, again, less than 0.1% of the preventable harm out there. Let's talk about the bigger issues. And the issue in value is really two component issues. One is the price of healthcare, and the other is quality. And if we can change the lexicon and use a more basic lexicon, instead of talking about healthcare costs, let's talk about medical prices. And we talk about petroleum futures, it doesn't have the same meaning as if we talk about gas prices. And if we can change the lexicon from serious, reportable, preventable adverse events to ways in which we can do better, ways in which we've made mistakes. If we can change the lexicon, instead of saying, oh, I didn't have to pay, my insurance paid, and instead recognize those premiums and dollars come from the same pool of money of wages and benefits that otherwise go to earnings for American workers. If we can change the lexicon, instead of saying, I didn't have to pay, Medicare paid, guess what? It would completely revolutionize our discussion. Just like in the banking industry, we had collateralized debt obligations and credit default swaps, fancy terms for spending borrowed money on risky investments. Let's change the lexicon. It turns out that of all federal spending, it's not just Medicare and Medicaid that goes to health care. Guess where seniors are spending their Social Security checks, which is a huge part of federal spending, 24%. Half, according to Kaiser Family Foundation, is going to co-pays, deductibles, co-insurance, and non-covered services. The Defense Department, the only part that people think is larger than healthcare, they have their own healthcare system. 15% goes to healthcare of their budget. They have their own hospitals, they have TRICARE. they have their own healthcare system. That's 15% of their 31% total expenditure of the federal budget. That's about 2.5% of all federal spending goes to the military's healthcare system, separate from the VA, which will be 4.5% this year. And by the way, we pay for healthcare benefits for 9.1 million federal workers and their beneficiaries and retirees. And that's not free. The country buys that on the open market. And interest on the debt is in part interest on healthcare spending. It's healthcare debt. And no one has told me that the 6% of all federal spending that goes to interest payments on the debt is projected to come down. I don't know any policy expert that thinks that. It's going to continue to go up. So what we have really is nearly half of all federal spending that goes to healthcare right now, and people have a right to be upset. They're spending money to healthcare through their tax dollars, through debt the country is incurring, and then they spend for health insurance, $20,000 for the average household in the United States today, according to the Kaiser Family Foundation. And then they get a bill and told it's not covered. People have a right to be upset right now. The insurance community is stuck with the problem of how to manage payments of these high prices. And I believe it's not their fault. They're trying to manage things that are out of their control. So let's take a look at the two underlying problems that drive up the cost of healthcare in a way that everybody can understand. I want to propose to you that we have two underlying drivers of our healthcare crisis today. You can go to the next slide. Are you controlling the slides, or am I, by the way? I got a little remote right here. So here, 48% of all federal spending goes to healthcare. It's the appropriateness of care, number one, and number two, pricing failures. These are the underlying issues. People give you a million different reasons why they think healthcare is broken. Talk to a cardiologist, they're going to tell you it's readmissions from heart failure. Talk to an OB, they're going to tell you it's malpractice premiums. Talk to a primary care doctor, they're going to tell you it's lack of care coordination. Everybody is right, but these are small contributions to our cost crisis, things around the periphery. The underlying problems, I would submit to you, are the appropriateness of care and pricing failures. Let's talk first about the appropriateness of care. Okay? We have a theme in the medical literature. In the last 7 years, there's one theme in all the publications, and that is that things that we thought were broad, indications to treat that we thought were broad, are more narrow than we appreciated. You can run the list. Aspirin, this just came out last week. Did people see the draft guidance for aspirin? So when I was in medical school, it was told that everybody needs to take a pill. For the first time in history, every healthy person should take a pill once a day for prevention, and that was aspirin. Okay? It turns out that we had seen lots of cases of strokes and GI bleeding that were not captured in the study. They were long-term downside consequences of anticoagulation like aspirin. Finally, the research caught up. It turns out that the risk of internal bleeding and the risk of hemorrhagic stroke exceeds the benefit of reducing deaths from heart disease. And that's why the U.S. Preventive Services Task Force just said in their draft guidance that will become their final rule that people should not take an aspirin once a day. They reversed it. Unless they're over 65 with a risk factor or have been on aspirin for a long time and have proven that it's safe in their system, we should stop telling everyone to take this. This is not just one thing. This is a theme in the medical literature. We're seeing it over and over again. Colonoscopy recommendations scaled back. Guidance to treat high blood pressure and cholesterol changing also with age. You don't need to start somebody who's 90 for the first time on a cholesterol-lowering medication. Diverticulitis, the list of indications to operate have gone from 8 to 2 today. Total knee replacement indications, papillary thyroid cancer, the number of ultrasounds we perform, screening criteria. All of these recommendations are being scaled back as we recognize that the appropriateness of care is a small fraction of the care that we've otherwise been providing. This is a massive theme in the medical literature. In my own field of surgery, appendicitis is treated now with antibiotics. 75% of the time, people never need surgery. I mean, this is revolutionary. What does it do to our operating room wait lists and the size of our hospitals? If there's one theme in the medical literature, it's that we need to be more appropriate, more precise. And the research is showing that, in fact, there's a subpopulation that benefits from our interventions, and it's not the broader community. And even in COVID, we're recognizing now that natural immunity may be up to 27 times more protective than vaccinated immunity in people who have recovered from COVID. This is from the largest population study done in Israel. Natural immunity may in fact be real and durable, and in fact, people who have natural immunity may not need to be vaccinated, or they may not need both doses of the vaccine. This is part of the broader issue of the precision of medicine. I'll have a piece coming out later today in the Wall Street Journal looking at kids 5 through 11. Guess how many kids 5 through 11 have natural immunity? Upwards of 50%. That's according to data from the CDC pre the Delta wave extrapolated to afterwards. Those children may not need both doses. They may not need any dose. We're recognizing that indications we thought were broad may be far more narrow than we appreciated. Why don't we have this data? By the way, we just did this study looking at where the government spent their money on research last year. Guess how much went to COVID research? 5%. And it's not even for the things that you would think. 54 grants on health disparities in COVID, an important topic. 4 on transmission, how does it spread? 1 on masks. These are important questions. So when COVID hit this country, we needed to pivot our research quickly. Within a week, we needed to round up people who had the infection and test them every day with PCR tests and get a viral load and figure out the curve of when the viral shedding is maximal, figure out how long people need to quarantine for, figure out how it spreads. Is it surfaces or is it airborne, which is exactly how SARS-CoV-1 spread. Turns out SARS-CoV-2 spread just like SARS-CoV-1. This research was not conducted, and as a result, we had a vacuum, a massive void of answers to the questions every American was asking. How does it spread? How long do I need to quarantine for? When am I most contagious? Do masks work? We didn't have the data to answer those questions, and guess what filled that void? Political opinions. And that's how this began to be the most politicized virus in pandemic history. Well, the NIH not only spent twice as much money on aging research last year than it did on COVID research, but the average time for them to give grant money for researchers to study COVID was 5 months. This is research that is not yet published, but we'll have it coming out because we need to learn from our mistakes so we can improve in the future. 3 months into the pandemic, the NIH spent 0.05% of its annual research on COVID. We were not funding the right things. And to this day, we still have a massive lack of appreciation for therapeutics, not the controversial ones, not the ones like ivermectin and hydroxychloroquine, where I personally believe those therapeutics have no activity against the virus. In reviewing the literature, that's where I've landed. But look at the randomized controlled trial data on fluvoxamine. 2 big randomized controlled trials. This is Prozac. This has been on the shelf for decades, reducing hospitalization by 91%. Okay? Another study in Lancet on fluvoxamine. This has been around. Steroid inhalers reduce hospitalizations by half. Hypertonic saline sprays, things you buy at the pharmacy, 19-fold reduction in hospitalizations in people with mild COVID in one study based out of Georgia. This is a randomized controlled trial. I mean, nobody gets rich off of hypertonic saline spray that's in the pharmacy. All of these therapies can be used in conjunction. And maybe one of the most tragic examples is that we just learned that the Pfizer new drug, which is based in part on the component molecule ritonavir, has been around for a long time. I went back and I said, that's familiar, ritonavir. I got a Facebook message from a classmate in medical school before the pandemic hit on March 11th, before the shutdown. And he said, Marty, ritonavir will block the protease enzyme of COVID-19. We immediately need a trial looking at it. Here we are, 19 months later, now just discovering the power of therapeutics that can be used in combination. They can be used in combination. Maybe we need to reevaluate how we think about the design of our healthcare system. I talked to a physician who happens to also be an immigrant, a little hyper observant of her setting, and just took a step back from the whole delivery process and said, we can do this better. It can be more natural, more, I don't know what the term is, she said, holistic doesn't capture it. Prevention is not really the right word. We're not talking about at what age to start mammograms. She said, there's just something that doesn't seem right. And I said, yes. I've also felt the same way, and I told her as a medical student, I noticed that the first thing we do when a baby is entered into the world, the very first thing we do to greet a human being when it's born is we stick a metal temperature probe into its rectum. Is this recorded? And I remember asking, why are we sticking a probe in the baby's rectum? And the doctor said, well, we have to record the temperature. And I said, why? Like, what are we looking for? Is there a pandemic of influenza among newborn babies? And they said, well, we just have to note the temperature. And I said, well, is it for the purposes of the sheet, or is there a clinical value? And they got frustrated with me, and they said, look, it's something that we have to record. And I said, the temperature of the baby 5 seconds after it's born is identical to the temperature of the mother because the baby was just in the mother 5 seconds ago. But we do these things without thinking, and it costs money. And so this doctor looked at this process, said, we're not going to do this probing the baby. We actually have the mom hold the baby and maximize skin-to-skin time. And we're going to do it for hours, 6, 7 hours, as long as it can be safely done. There'll be a helper there coaching, watching, make sure that the mom may be tired and safely holding the baby. And if we need to suction the baby or something, we'll do it while the baby's on the mom. And they cut the umbilical cord in a delayed fashion after they see the pulsation stop. Not the second we see it, which is what I was taught in medical school. Oh, there it is, cut it. It's flowing nutrients and blood and stem cells from the placenta and antibodies, including COVID antibodies if the mom has them. And they don't take the baby away and put the baby under a French fry light. They have the mom hold the baby, and they don't wash the baby because the bacteria from the vaginal delivery form the ingrowth of the microbiome, something we've barely understood in medicine. And so they said, we're not going to just, why do we wash a baby? Just to give the mom a shiny baby? We just gave the baby, let the bacteria form the microbiome. And so she started this amazing protocol here in Texas, in a hospital in Makary, where they maximize skin-to-skin time, delayed cord clamping, don't wash the baby in the first 3 days, and they try to preserve the natural process. Guess what? They've now published data. The babies need fewer vasopressors, fewer NICU admissions, shorter NICU admissions, fewer blood transfusions because the blood is pulsating to the baby naturally. And so they've done all of these things, and they have amazing outcomes. The glucose levels are much more normal. Why? Because the stress hormones of the baby are not spiking after birth. This is the theme in the medical literature, that what we have been doing has been too much. We have two problems in medicine, overtreatment and undertreatment, but by far, overtreatment, doing too much stuff, has been dominating the system. And if there's one theme we need to listen to in the medical literature, it's that we can be more precise. We can be more appropriate, more holistic. There's a movement now to look at this. A movement saying, hey, we need to talk about food as medicine. When we talk about back pain, maybe we need to talk more about ice and physical therapy instead of just surgery and opioids. When we train our medical students, maybe we need to train them differently. Maybe it's good to have an ICU where the ventilators are not being used and the ECMO machines are getting low utilization. Maybe we need to talk about managing high blood pressure by talking about the sleep science behind the muscle tone in the blood vessels increasing, and stress management. Maybe we need to talk more about body inflammation as a predisposition for inflammatory bowel disease, Crohn's disease, ulcerative colitis, conditions that were obsolete and undescribed before the introduction of penicillin. Maybe because the microbiome finds that to be a stimulus. Maybe we can treat more back pain differently. Cooking classes for those with diabetes instead of just giving insulin to people immediately, which can increase their appetite. Maybe when people come in with cancer, we need to talk about the environmental exposures in their life. And when we study cancer, maybe we can talk about the environmental exposures that cause cancer, not just the chemotherapy to treat it. This is the movement right now to say we want to get at the underlying issues that bring people to illness, not just the illness itself. People don't want to be a part of our current primary care system. It's broken. I mean, who likes it? You come in, and the doc tells you to eat better and exercise more, and here's some meds, come back in 6 months, and you come back in 6 months, and we tell you you're a bad, non-compliant patient. Patients don't like it. The docs don't like it. Why are we doing it? So a movement now is saying, look, we're going to do things differently. We're going to do things entirely differently. We are going to redesign care so we can actually talk about the underlying things that bring people to care, not just the care itself. When we have talked about measuring quality in medicine, we're really just talking about the consequence of care. Think about this description. Somebody comes in and we do something. Let's say we do an operation, and then we measure the infection rate after that operation. We're really not measuring the quality of that operation. We're measuring the consequence of doing that operation. What we're missing is the first arrow. What we're missing is the appropriateness of that procedure. Now, I was speaking at a big spine surgery conference of neurosurgeons. Easy surgery, by the way. Brain surgery is easy. And they tell me that half of the spine surgery done in the United States is unnecessary. I don't know. I don't do that type of surgery. But if they are right, we have a crisis of appropriateness. That's one of the highest ticket items in the entire system next to some NICU and critical care stuff. Maybe we can talk about this first arrow. Maybe we can talk about the appropriateness of care. So we submitted to the Robert Wood Johnson Foundation a project to say we want to look at patterns of doctors, not just the consequence of doing something. We want to measure the first arrow, not just the second arrow. And so we started talking with doctors around the country, thousands of them now over the last 6 years, collecting their wisdom on patterns of overuse. Now, we have also narrowly painted ourselves into a corner in the field of quality science because we said we can only have quality measures that are on an always do, never do pathway. Okay, it's got to be you always do this or you never do this, right? It's not how the real world works. You got to tailor treatments and respect physician liberty. We've also said we can't have a quality measure unless there's evidence. They have to be evidence-based. Who can be against evidence? And evidence is narrowly defined as a level 1, 2, or 3 study, with one being a randomized controlled trial. And if you show something, as we're seeing now with COVID, with level 3 evidence, nope, I need to see better evidence. Here's a level 2 study. I need to see level 1. Here's a level 1 randomized controlled trial. I need to see 2 level 1 randomized controlled trials. Okay, at this point, it's unethical to do any more research. Because you cannot ethically randomize people to placebo sometimes. So we said, we like evidence, sure, who can be against it? But we're going to not only use evidence to create patterns of appropriate care, we're going to use clinical wisdom. Because 60% of what we do in medicine is discretionary. And so we've met with doctors and asked them, tell us in cardiac surgery, is there a pattern of overuse that is not an always do, never do clinical pathway? It's not something with a randomized control trial, but you believe in your heart that there's a pattern of overuse. And they say, oh yeah, let me tell you, when it comes time to replace, when a mitral valve is not working and you go in there surgically and you see the shape of it, and you see the tear and the contours of that mitral valve, you can either replace it or repair it. And you can't predict with any certainty the ones that need to be repaired. If you can repair it, it's better for the patient most of the time. And so it's clinical judgment. Now, if you replace it, by the way, it's easier, pays more. You cut the chordae tendineae, which anchor that mitral valve in the ventricular wall. Turns out those chordae tendineae are not just anchoring the valve, they're also providing important architectural support for the ventricle. And so when you cut it, guess what? The muscle is more likely to balloon out over time. Now, it's easier and faster to sew in an artificial valve, but it's better to repair it. There's no always do, never do pathway, but we can measure now using big data practice patterns where we identify the doctors that never repair them, always replace them. We ask the doctors, look, what % of the time should you be repairing the valve at minimum? And they have lots of opinions, lots of debate, lots of discussion. We listen to these arguments like we're a Supreme Court, and we come down and we say, you know what, these people that we're talking to, there's broad consensus that you should be repairing at least 10% of your mitral valves. And if you're below that, which turns out is a fair amount of the cardiac surgeons, that is a pattern that's indefensible to a group of peers. We are using practice patterns now to capture appropriateness. We have the same thing for appendicitis. How often are you operating on it? Umbilical hernias in kids. You should let the hernia heal on its own. If somebody has an umbilical hernia, let the hernia will heal by the time the kid turns 5 or 6, 99% of the time. 1 or 2, 3% of the time you need to operate. But if you're operating on 100% hernias that you see, or hernias in kids under 5 represent more than 60% of all the hernias that you're repairing in children, that's too frequent. There's no RCT, but that's the clinical wisdom. In this field of Mohs surgery, the Mohs surgeon said people are taking too many sections when they remove a skin cancer lesion, and you get paid per section or per stage. And they said the pattern of overuse here is taking out too many sections. It's created by this perverse incentive. Well, most surgeons do the right thing and always try to. I believe that of all doctors. But there's a subgroup that responds to these perverse incentives, and we identify them by graphing all the Mohs surgeons in the country on a bell curve and showing the outliers, people above the dotted line of the boundary of what's appropriate. This is your performance, average stages per case or sections per cancer, relative to every other Mohs surgeon in the country. Cover letter, friendly cover letter, and the data and the cover letter says, as a courtesy, we want to let you know where you stand. Guess what happened to the outliers? 83% reduced their pattern of overuse immediately, and it was sustained at 2 years. This little letter program saved $2 million in the first year and $6 million in the second year. Now, CMS did something similar where they wrote a nasty letter if you're prescribing too much Seroquel. And they also noticed about 80% of doctors reduced their pattern of overuse. So it was interesting. If the letter was nasty or friendly, it had the same result, probably speaking to the power of the data itself and the measure. These measures are developed from clinical wisdom. Now, what do we do with the appropriateness measure? Some groups are saying, hey, we can actually use this information to figure out which doctor to send you to from primary care. As a part of care navigation, do you want to go to the spine surgeon that never uses conservative therapy before going to spine surgery? To the spine surgeon that operates on more than 3 levels of vertebrae in non-deformity conditions in more than 30% of his or her practice? When you test positive for pregnancy, do you want to go to a doctor with a C-section rate of 48% in low-risk deliveries, according to their data? Or do you want to go to the doctor who delivers babies with the holistic approach that we saw in Makary, Texas? This is the holy grail of healthcare: steerage, navigation, quality, measuring appropriateness, and doing it with both price and quality as a factor. This is the power of steerage to create demand in the market for real quality. If there's one fundamental problem in healthcare, Dr. Roy's done a great work in this, it is that healthcare is a non-competitive market. And when you see non-competitive markets and monopoly pricing, the temptation is to create rules around the bad behavior, but the fundamental change that's needed is to transform those non-competitive markets into competitive markets so that they are competing on quality, appropriateness, and price, not on billboards at NFL games and valet parking. I had a patient come to me and I asked, as a health services researcher, just out of curiosity, why'd you choose to come here to Johns Hopkins? And I'm thinking, we do more pancreas surgery than any center in the country. And the person said, you know, I came here because the parking is the easiest in the city. We have competition in healthcare, but it has not been at the right level, and many of you are driving it to be at the right level. Many of these direct primary care clinics now are using good metrics and algorithms to steer people to the good doctors at the fair prices. This is the movement in healthcare. And I will tell you that this value proposition that is such a buzzword in healthcare is really just two fundamental components, price and quality. When I ask folks, how are you measuring quality in this new, say, CMMI bundle? They always make it sound like we're on the brink of finally getting good quality measures. Well, we've been almost stagnant in the field of quality measurement for 25 years. Speaking as somebody in the academic space of quality science, we need to start finally talking about appropriateness of care. These new clinics are spending tremendous time with people, getting into the underlying issues that bring them to care. In the pricing space, if we can close by just talking about pricing briefly, this is probably one of the most symbolic studies done in recent time. Researchers at the University of Iowa called 100 heart hospitals that offer standard CABG operations and said, how much is the operation? I'll be paying in cash. Half of them could not give them an answer, and they tried, and it's not for lack of trying, they called everybody, the CFO, everybody at the hospital, voice menu, get transferred to a rat lab and call back, and finally they got the price at half of those medical centers. The price ranged from $44,000 for a standard CABG to $500,000. They then took those prices and ran a correlation study between the outcomes in the STS, Society of Thoracic Surgeons, quality registry, which you may know is the most advanced and sophisticated quality registry in all of healthcare. Independently abstracted outcomes, embraced by the society, and guess what? The very standardized CABG procedure, no correlation between price and quality. Some of the best hospitals for CABG surgery were also some of the cheapest. Well, they offer charity care, many hospitals argued, and we would talk to the CEOs. They would boast about their charity care, although it's very difficult with cost shift accounting sometimes to understand what that true community benefit is. And in fact, what we found is there was no correlation between charity care and their price. It was haphazard, it was random. This is what's frustrating everyday people in the United States. People like Jimmy Joe, who goes to an emergency room, and as we met people who have been hunted down by hospitals for simply not being able to afford their bill for emergency services, we got to know these people. We have a medical student on our research team who is a filmmaker from his previous time before medical school, and he said, you know, Marty, I want to help. I said, capture these videos so people can understand what's going on out there. It's not as simple as so-called bad debt collection. Let's change the lexicon and call it what it is. It's price gouging and predatory billing. So this is one of the videos. If you want to play the video of Jimmy Joe, feel free to.
We're not making any money. I'm a housewife, and he just stopped working recently.
I'll go out and help a buddy do some work just to get a few $100s to help feed the family. And by trade, I'm a carpenter. Well, she didn't want me to worry, so she didn't tell me till last night. I just got the news last night.
Yeah.
I didn't know.
It's like we owed $5,000 some for, I think it was 2 visits, ER visits. $5,000, it's a lot of money, especially people that, don't have any money.
It's hard. It's a struggle. I know that.
They didn't say it was, how much it was going to be, nothing. They just sent us on out the door with just discharge papers saying what he was,
Diagnosis and all. That's right. That's exactly right.
When you go into the ER there's no price of anything. Even when you ask people, they don't tell you anything.
So they can really put any number on
They
there.
put anything.
And you don't know any prices.
Until weeks later when they send you the bill. It's nothing you can do. It's their rules and it's their policy, and it's kind of like a monopoly. You have no choice. If you're sick, you're that sick, and you have to go to the ER, you have no choice.
Is a person who does handyman services. His wife works at a fast food place. It hit me in talking to these folks, all of whom had been sued by their hospital to have their wages garnished over prices that were massively jacked up. We reviewed their bills. About a third of all the services we've reviewed were services that were not necessary. And of those who got billed, most of those bills were egregious. It hit me in talking to them. Most people don't live like us. Most Americans live paycheck to paycheck. Half of Americans have less than $400 of cash on hand. And when they get a bill, $2,000, it's very different. If I get a bill for $2,000, I'll make it go away by just paying it. For them, it is devastating. And these are the people who have been forgotten in healthcare. These are the people that all of you in this room represent in your work in the healthcare system. They have no stakeholder. They are relying on you and your advocacy. And you are fighting for them, and for that I thank you. We did research looking at how commonly hospitals sued patients. We found in this study we published in the Journal of the American Medical Association, one hospital sued 25,000 people to garnish their paycheck in a town of 50,000. In New Mexico, they sued the judge by accident. Her husband went to the emergency room. We found a woman who had been sued over a bill because she checked into an emergency room and left before she was taken back or evaluated because the wait time was too long. We found the most common worker was a Walmart employee sued in the state of Virginia, followed by food service workers, followed by hospital employees. Hospitals are the largest employer in most towns. These are not people who can easily handle these bills. These are people being destroyed after half of our federal spending goes to health care, and the average household is spending most of them were insured, $20,000 on health care through their pool of wages and benefits. These are people who need our help right now. We used to publish in the medical journals, and now we just go on the Z-Dog podcast and talk with Peter Attia and make things happen right away. When we realized we're being held hostage by this editorial board system of the New England Journal and JAMA, we decided, a bunch of us, to protest it. We're no longer going to be publishing in these journals. Sure, we might do a couple. After 300 scientific peer-reviewed articles, we realized nobody's reading our papers. And so we've got to stand up. So now we're using new channels. Z-Dog has a collective audience that has 1 billion hits on all of his platforms, the largest influencer on all of healthcare. We go on there and we ask the hospitals to stop the practice of suing patients, predatory billing and price gouging altogether. And if they don't comply, we talk about them on this program that Z-Dog has. This is very effective. When hospitals were shutting out loved ones from visiting their dying COVID relatives, this was clearly wrong. I mean, what were we doing? Telling a 19-year-old they can't say goodbye to their mom? I mean, so we called out immediately the hospitals as participating in what we called a human rights violation. We can't wait for the journals and the field to change itself. We can't wait for the agencies to reform themselves or for them to decide to fund things differently. We've got to move quicker. As a result of our advocacy efforts immediately following the publication and in conjunction with the book, The Price We Pay, we were able to get 80% of hospitals that sued patients to agree to stop suing patients altogether. We defend these people in court, and we've gone toe-to-toe with them in front of a judge, and we win 100% of the time. And we will continue to fight this until we shut down the practice of suing people for bills they cannot afford to pay. Thank you. Thank you. Somebody at Google had read my book and invited me in, and I went to the executive offices, and they said, well, what can we do to improve, to help with the price of healthcare? I said, well, you guys are Google. When somebody types in the name of a hospital, don't just put the name and address. Put the name and address and average price markup of that hospital and how they perform on billing quality. We published in JAMA a follow-up piece that created billing quality measures, looking at 6 basic areas of billing quality where a hospital can be rated with a simple 6-star score. And they can be measured recognizing that billing quality is medical quality. And financial toxicity is a medical complication. None of us took an oath to help somebody and then ruin their life financially. And we've got to recognize that taking care of a person is taking care of the entire person. So we're now working with many of the ratings agencies to get the billing quality score to be public information and allow public accountability to keep our community hospitals in check. Many hospitals do well on billing and pricing. They're fair and they're honest, and they've worked with many of the payers for a long time in a good, healthy relationship. But now many have crossed the line into price gouging and predatory billing simply because they can. Well, now with Axios, we have a rating system for the top 100 US hospitals, and we're going to continue to work with Yelp and Google to get our rating system out there. The fundamental problem in healthcare is we have non-competitive pricing. And if we can create demand for honest billing practices like we can for good appropriateness measures and quality, we can change the marketplace to compete. Instead of parking, it'll compete on value, quality, and price in healthcare. When American hospitals were built, they had a charter dedicating them to serve their communities regardless of one's race, creed, or ability to pay. Many of them have amazing charters. Many of them were started by churches and philanthropists, and they were dedicated to making sure that their services were available to everybody. My own hospital took care of soldiers on both sides of the Civil War, which crowded the lobby. Didn't matter who you were or what you believed in, the hospital was there to take care of you. Benjamin Rush, one of the founders of America's first hospital, he was a psychiatrist. His son had mental illness, and he was committed to taking care of people and destigmatizing mental illness. He was highly respected, didn't make a lot of money. His patients with schizophrenia couldn't pay him anything. He took care of them anyway. That was part of the calling. An incredibly respected man in the early Americas. He was the co-founder of Pennsylvania Hospital with Benjamin Franklin. When he died, it was around the time Benjamin Franklin died, and the President of the United States, John Adams, said at the time when they both died, both Benjamin Franklin and Benjamin Rush had significant contributions to America's early society. But by far, Dr. Rush had more. That is the incredible heritage of the medical profession. When polio hit this country in 1954, Jonas Salk had seen reports of upwards of 20,000 people committed to an iron lung machine, committed his life to inventing a vaccine, which he successfully did. Around the time Sabin invented a similar vaccine, but the Salk vaccine became the dominant vaccine. It was first, and he said, this will be available to everybody as soon as we can try it on ourselves as physicians. His friends told him, you need to get a patent. This will be the most lucrative patent in the history of the patent office. And he said, no, this will be a gift to humanity. This is the property of mankind. So as many kids in the world can get it as possible. You talk about a patriot. This is our great heritage of the medical profession. Not one of overtreatment and gouging people with predatory billing, one of taking care of people with time and getting at the underlying issues that bring them to care. As we think about the next chapters in healthcare, let's remember the principles of Salk, Sabin, Benjamin Rush, Samuel Gross, and many other folks who have taught us that our sacred oath in the medical profession is to take care of anyone regardless of their race, creed, or ability to pay. I'll leave my contact information up here. Good to see all of you. Take some questions, and thank you so much, Jamie, for having me.
Do we have any questions? Does anyone? Oh, here we go.
Hi, good morning, and thank you, Dr. Makary, for a very inspirational and very insightful talk on appropriateness of care and pricing failure. So my question is, what are we trying to do for our trainees and medical students in terms of maybe redesigning curricula to address some of these topics? Because I do believe that time is now right to engage with our learners to tackle some of these issues, because these are tough issues, and once we become more seasoned physicians, we get into our boxes, and you know, we as specialists, sometimes it's very difficult to unbox our thought processes and make necessary changes. But I think as trainees, medical students, and fellows, if they understand, if they believe in the fundamentals of these factors driving the cost and inequality, perhaps we'll build a better workforce who are very passionate about these topics. Thank you.
Well, thank you. I appreciate that question. And I think it really starts with the concentration of power. We've got a small group of people making all the decisions in healthcare. With regard to the curricula, it really boils down to one person, the head of the AAMC, who decides what's going to be on those exams through that board. Now, we don't need to be asking young people to tell us the 9 intermediate molecules of the Krebs cycle on memory, on demand, 7 different times in their medical education, from pre-med to end of fellowship training. We don't need to tell them to do that. We have computers now. And no one needs to know, how many ATP are in something on demand in the trauma bay. We have this archaic system, and what we've done is created a generation of people where they start off amazing. They come in, they interview for medical school, they're well-dressed, they're athletic, they're charitable, they've spent 2 years developing a child vaccine program in Nicaragua. And it's like, I may have rotated in the emergency room for 2 days before I applied to business. And they're amazing, they're bright, talented, altruistic, and we take them and we beat them down with this rote memorization and regurgitation as if that's the model of learning, and they come out with this reflex. The only way you can learn all of this data is to pair things. Diagnosis, treatment, diagnosis, treatment, diagnosis, treatment, and they come out, gout, colchicine, x-ray finding, knee replacement. They come out with this reflex, and what we lose is the threshold of appropriateness. And so we don't teach about it because they're smart enough to know, even the students on my research team, look, I got to get through those board exams. All the other stuff is soft. I'll figure it out on the fly down the road. It's not testable. We've told the students you've got to do well on these board exams. This is the first year the board exams have gone to all pass fail. You don't even get a grade. And it's going to be even optional for one of the board exams to even take it. That's a step forward. But that is an important part of the future generation. By the way, the new students coming out, they don't want to live like us. They don't want to practice every day. Half of them are planning on not practicing full time. That's in their second year of medical school. Why? Because they see a broken healthcare system they want to fix. They want to go into innovation and entrepreneurship and early stage companies, and they want to do things creatively. And they see groups like the emergency room doctors that said, hey, we're going to do house calls. We're going to have our own triage line. And they see people delivering food and the IORA and ChenMed and holistic care, and they think, that's what I want to be a part of. And they're totally rejecting the status quo system. We've seen it with COVID. We've got a few people making all the decisions right now. Turns out there's a lot of different opinions out there. You know, I've been one of them, where we're saying, hey, wait a minute, it's good to have a healthy, robust discussion of many different ideas instead of a more paternalistic approach. So the young people see it, and I think we need to encourage that right now.
I think we have one over here.
Yeah, I was gonna say, I think we have time for one more question.
Yes, Doctor, thank you for your presentation. And I was curious your thoughts on what do you think would happen, the improvement of the effectiveness and efficiency of healthcare in the U.S. if it was made public CMS data on the cost billed by a provider, the cost CMS paid. What is the percentage, what's the frequency of a repeat procedure done? So let's say a physician does something 17 times on a patient, but then you see another physician that doesn't have any repeats, so they probably did it right the first time.
Yeah.
And then, on a personal experience, driving in Corpus Christi, I've seen advertisements for physicians that claim they do these certain procedures that that might pay well. Well, I've had access to the CMS data. I've looked them up. They do less than 10 or less per year. So if they're supposed experts on it, why aren't they doing it? Whereas a real expert on it may not be. It's just it could go either way. But anyway, basically public data of that. What do you think? How that would improve the U.S. healthcare system?
Yeah, so
Thank you.
Thank you for the question. So we're getting great data right now, but it's hard to interpret, and it needs to be translated to make it an easy user interface for consumers. Look at, for example, many of you know I was involved in the price transparency executive order for hospitals to show real cost estimates and also disclose their cash prices for common shoppable services. Well, the information they got's not legible. It's not interpretable for everyday consumers. So now a group of companies are coming along saying, we're going to interpret this for you and make it very easy for you to understand for navigation purposes. So I think eventually we will break down this data. Now on the national data, we have been in the field of quality science stuck in this corner where we're just looking at utilization. Now, you look at our pancreas transplant team, we have probably off the charts utilization on a lot of things. Doesn't mean we're bad, it means that we're one of the only centers in the country to do pancreas auto transplant procedures, minimally invasive. So we've been stuck in this field where the only measures we've had, because we've insisted on evidence-based and other things, is we have utilization measures which are crude. And if you measure doctors in a mediocre or poor way, they will fight back with fire and have a right to, because there's a huge difference between a mediocre quality measure and a superior quality measure. So now we're trying to create clinically wise measures that don't just look at total utilization, but they look at frequencies in certain clinical situations. And many of you in this room have been working with us on our national project called Global Appropriateness Measures to take those appropriateness measures into the field and are using them for ways of helping navigation, network sculpting, and other things. But the doctor who has the C-section rate of 61% in low-risk deliveries in Florida, and I know the name, should not be getting any patients, right? That doctor should not be getting any patients. We talk to the residents, we talk to the nurses that doctor works with. We have a team who actually, honestly, our statisticians are morally set back when they see the data on these individuals. And they come up to me almost in tears like, Marty, what are we going to do about this person? And I say, well, we got to go to the professional association and use it in the insurance market for steerage. And they're like, no, today, like, these young people have a social justice mentality. It's a generational value for them. And so they're the ones looking up the doctors, sometimes calling, sometimes sending the name to the state medical boards. We see these egregious patterns. Right now, our system is blind, and people are flying blind, and the market rewards those high utilizers. So that's what we're trying to disrupt or change in the way that we measure quality today. And I think the data transparency is going to go a long way on both quality data and pricing data.
Great, thank you.
Yes. Happy to talk about that. We have taken as a physician, what I've found is that if you sometimes win more bees with honey than fire, and if we can say, hey, we want you to develop the measures, you to apply it, write the cover letter, or give us your sort of blessing, and then we'll empower insurance companies to use this. They can identify outliers. So when you show an outlier that they're an outlier, they auto-correct. So there's a lot of different strategies and paths. For now, we're trying the friendly approach that is so-called doctor authored, doctor developed, and doctor implemented. And that way it's received better. If you remember, ProPublica did a doctor profiling thing a couple years ago, where they basically did the same thing, but they just looked at like who had the highest death rate after prostatectomy and certain things. And the medical field pushed back on them so hard they threw them under the bus. They had editorials in the New England Journal of Medicine that this doesn't meet their elaborate risk adjustment standards. And all of you know this battle, right? This battle between my patients are sicker and you don't understand, and oh, they had redness and I didn't document that. And this game of workarounds is an exhausting, expensive game. But when we look at patterns, we can say, look, peers in your own specialty say there's no justification for a C-section rate in low-risk deliveries greater than 26%. So that's the field of quality science we're trying to charter right now.
Thank you so much. Will everyone join me in welcoming Dr. Marty Makary and thanking him?